You are listening to the Movement Therapy Podcast.
Hello everyone, welcome back to another episode of the Movement Therapy Podcast. This week we're jumping into part 2 of our episodes with Dr. Tom Cross about the cross bracing protocol. In our first episode we talked about the protocol itself and the technique and also the anatomy of the knee. But this week we're going to be talking about the recovery process and also the healing. So we'll be looking at your rehab stages, what usually happens during your healing process, and also your prognosis and your return to sport. So listen in, and as always, let us know if you have any questions, but enjoy.
So as a clinician, if you do have a high velocity impact injury, whether it's direct or indirect, should the advice be, if you don't have that physio on the sideline or the physician on the sideline, would it be straight to the GP and get your own sort of MRI? Would it be straight to a physio that you trust to get an MRI straight away, even as you're suspecting an ACL, just to rule it out?
Yeah, the shift in knowledge or the new paradigm of thinking is hopefully in the general community, and this will take more publications and research and greater gravitas of science to disrupt this belief that some ACLs are indeed healable.
Yeah.
The community will drive it because they're now they're very empowered patients.
Yeah.
So they search the internet.
Yeah.
They should find a doctor that has a real interest in sport if they're a GP. So with the greatest respect, some GPs really don't like sports medicine and orthopedics.
Yeah.
But you need to find one that loves sports medicine, that's involved in the community. There's a team doctor, knows what an ACL injury is.
Mm-hmm.
So if you've got a GP like that, fantastic. And they've got, in Australia, the ability to do a Medicare rebatable MRI if the patient's under 50. And then that doctor hopefully has an awareness of what we're talking about today in the podcast. And then that doctor might be able to enact the cross-bracing protocol, him or herself.
Sure, yeah.
And so what we talked about earlier, Zoe and Ethan, is to enact this treatment in Australia, you need a team of 4 people that are interested in ACL, knee injuries. And that team needs to be a doctor, a physio, a radiologist, and a surgeon. If you get on a plane and go to the Pacific Islands close to us, just as far away as Fiji, they often don't have the team of 4, unfortunately. So it's very hard to get an MRI in Fiji or some parts of the world that just don't have the finance for having an excellent radiology clinic with a radiologist sitting in there. And they're very hard to get an orthopedic surgeon. So you might have a team of 2 in certain parts of the world, and that team of 2 will be the physiotherapist. That most parts of the world do have physical therapists. There might be a nurse or a doctor, and you can enact the treatment empirically without an MRI and a surgeon in these parts of the world that don't have access to imaging and surgeons. But in Australia, you'd have ideally a doctor that really understands what we're talking about today. The doctor needs to write the referral for the MRI and do a thorough history and examination of the patient, get to really, who is the patient, what are their medications, what are their medical comorbidities, what's their social situation, are they insured, uninsured, do they like surgery, they've had a bad experience with surgery, and then get the MRI at a great facility, talk to the radiologist. In the meantime, they're talking to the physio who loves ACL and knee rehab, saying that we might have a patient that's either going to do surgery or non-surgical management. We're just working them up. And then you go back to the patient and the patient decides. So it's a shared decision between the doctor, radiologist, patient, physio, and the patient goes, well, okay, you're telling me I've got this ACL injury, I've got these other injuries, this is what I want to do in 12 months' time and beyond. This is how I might heal with rehab alone. This is how I might heal with one of many bracing protocols. And this is what surgery looks like. And then the patient says, well, I think I should do this.
Yeah, they decide.
And they're very empowered.
Yeah.
2/3 of the patients I see at the moment, either they choose surgery or I'm sending them to surgeons.
Yeah.
So as a rough ballpark figure, the patients that come into this office or reach out to me by telehealth, it's about a third
Yeah.
that are appropriate,
Yeah.
that I deem are appropriate or they deem are appropriate.
Yeah. I think a lot of clients that come into the clinic that have the ACL confirmed, and it's tricky when they are a candidate, and I've been on the phone to you or your receptionist and they're sort of going, yep, bring them up, and then the patient goes, oh, I don't really want to. This is where it's like, oh, but this will be so much better for you. Can you please do it? That's the tricky part. You're trying to convince them that this is the thing that would be the best thing for you.
Well, the critics would argue with that, Ethan, that we don't really know that yet.
Sure. Yeah.
We need more science with greater, rigorous follow-up. We need more, years of data, but it's pretty compelling at the moment. Otherwise, I wouldn't be doing this.
No, absolutely. Yeah.
So,
and we wouldn't implement it in the clinic.
Yeah.
We're so keen for it.
Yeah. So there is, but you've really got nothing to lose.
Yeah.
We can talk about the complications of the treatment.
Yeah.
Which are, I tell them, well, number one, it may not work.
Yeah.
So we call that a poor healing outcome for you. And I, based on my, artificial intelligence in my brain, of seeing all these MRIs, all these patients, I can give them a rough idea in a percentage term of what I think, where they might land. And then I say, look, there's a 15% chance of a poor outcome if they've got everything going for them. Minimal gap distance, they're sitting in here in the first week. There's minimal detensioning of the ACL construct, there's no displacement out of the notch. But if they've got other worrying features, I give them like a 50-50, and I tell them this is the most likely healing outcome. So that's number one, it may not work. Number two, you could get a DVT. We need to put you on an anticoagulant. And then some people say, no, that's not for me, and that's okay.
Sorry to interrupt, that DVT is just because the knee's not moving, is that correct?
And you're going into flexion, and there might be a little bit of turbulent flow around the corner in behind the knee, the popliteal fossa. So in the beginning of this research, my father and I spoke to eminent hematologists, vascular surgeons, vascular physicians. We wanted to make sure it was safe. And we wouldn't hurt anyone with a DVT, pulmonary embolus, God forbid.
Which is worse than an ACL injury.
It's just an ACL.
Yes.
It's their knee, it's not their brain or heart.
Absolutely.
Their life. So we got really good advice that we should Doppler everyone that comes into the clinic before offering them the treatment. And after the first 400 patients, the only people who had DVTs were the travelling ACLs. So they got in a car and driven, 5 hours back from the snow.
Sure.
Or they've driven, 4 hours from, Dubbo to Sydney. And then the people flying in from Japan or, USA, North America, Europe. Unfortunately, they're the ones who arrive in the clinic with a DVT. But anyone who stayed in Wollongong, Sydney, Melbourne, Brisbane, and just stayed where they live, none of them got DVTs. So that was really interesting. But we were told that anyone that looks like an adult needs to be anticoagulated. So a 15-year-old boy or girl that's looks like an adult, and they've definitely reached puberty. They're in the latter stages of puberty. They're at risk of a DVT. You put them on a very low dose of a tablet at night called rivaroxaban or Xarelto, and some people prefer apixaban, which is morning and night dosing. You don't use aspirin. In the beginning, we used Clexane, injectable. But then quickly, the advice was just use a tablet at night. It's just as effective, much easier.
Definitely.
So the risks are poor outcome, DVT mitigated by the Xarelto. If you're on the anticoagulant, you can bleed more if you cut yourself or fall over. For women, they can get increased menstrual bleeding. But we've only had one woman who had to stop doing it because of that complication. She already had very heavy periods. She was perimenopausal, but most of the women do tolerate the treatment. And then the next risk is a stiff knee, mitigated by excellent physio. Muscle wasting in the brace, once again mitigated by excellent physio.
And that would be more like hamstring rather than quad, or is it kind of both?
Everything. So you do need a motivated patient to do this treatment. So people listening, if you wanted to sign up to the non-surgical management of your ACL. You have to be highly motivated to work with your physio, go weekly, do all your rehab at home. Even better if you can afford the time and money to go twice weekly.
Yeah.
It goes for surgery too.
Definitely.
You need an excellent surgeon,
Yep.
an excellent physio, and a patient that's highly motivated to get the best result. It's the same with these non-surgical treatments. And then finally, the next risk is re-rupture of the healed ACL, which we call survivorship or re-rupture rate. And we're sitting at, as I said, 15 to 18%.
Yeah.
And that's equivalent of an excellent knee surgeon, the graft survivorship.
Yeah.
It sits around 15 to 20% for,
That's phenomenal. I'd take that.
Yeah.
That's great odds.
Yeah, absolutely.
But they're the high volume heals, the ones where you get a large volume of healing that's parallel to the Blumensatz's line or parallel to where you've restored the anatomy.
Yeah, sure.
I think the thinned or elongated healing outcome wouldn't be in the 15 to 18. It's probably higher.
Yeah, definitely.
And we're teasing out those stats.
Yeah.
As we speak.
And like you said, they're changing weekly, as you said.
Yeah, but watching that metric super
Yeah.
carefully, and so we can give the feedback to the patient.
Definitely. And what about the pros? So obviously they're the cons, in taking the obviously as well the time in the brace of just trying to get around non-weight bearing with a knee at 90 degrees is tricky, especially if they're a little bit older and don't know how to use crutches, for example. They could be confined to a wheelchair, that potential. What about the pros of actually doing it? What are we as clinicians saying to the client to convince them or give them the best data that this is actually a really good option to start doing?
So for some people, it's a no-brainer because they don't have access to surgery. They don't have health insurance.
Sure.
They don't. If you have to pay privately for the surgery, within a matter of months, it is expensive.
Yeah.
And a lot of people can't afford it, and so they might put themselves on the public hospital waiting list, and then do the bracing protocol while they're on the waiting list.
Sure.
So they say,
because that might be 12 months, 18
could
months.
be like some surgeons in Australia their waiting lists are 5 to 6 months.
Yeah, okay.
That's the quickest I've heard of.
Yeah, that's very quick.
But the average in Australia would be anywhere between 10 months to 18 months.
Yeah, sure.
So the patient's waiting anyway for surgery. So they say, well, why wouldn't I try to facilitate my ACL healing? Because I might get enough healing that is acceptable for me.
Yeah.
So that's the first thing so that's a benefit. The other benefit is it's arguably cheaper than surgery. Even if you're privately insured, there's often a gap rightly so that there's a lot of people to pay who have got high skills to reconstruct someone's knee. You've got to pay the hospital, the surgeon, the anaesthetist, the surgical assistant. It's a wonderful thing that we've got surgeons who can do that, and anaesthetists and nurses in that team to try and enable that patient to have a stable knee.
Yeah.
So the cross bracing protocol depends on how often you go to physio, but if you add up the costs of the cross bracing protocol, you've got to see a doctor, someone like me, or any doctor who knows the treatment. You've got to see them minimum 3 times. So initially 12-week follow-up and 12-month follow-up. And then in between, the doctor should be available to see them if there's any problems along the way in the bracing period, which might be 6 weeks, 8 weeks or 12 weeks. And then see them anytime afterwards, when they're doing their non-surgical rehab from week 12 to week 52, returning them to sport. Then they go to a physio weekly for the first usually 12 weeks, and then the physio spaces it out. So they might do 20 to 30 physio appointments in that 12-month period. Then you've got to pay for the brace, then you've got to pay for the anticoagulant, and then the MRIs. So if you add all that up compared to surgery, it's usually 75 to 80% cheaper.
Sure. Yeah.
So that's very appealing.
Definitely.
To a lot of people for their son or daughter, or for themselves to go through it. And the other appealing feature is not having a general anaesthetic, the risk of infection, donor site morbidity, or where the surgeon has to take from somewhere to give to somewhere else.
Yeah.
They often take the hamstring, or as we talked about, patella tendon. The patient can have pain and suffering from where they've taken the tendon to become the new ACL.
Sure.
So that's called donor site morbidity.
Yep.
And that's why some patients who have had reconstructions of their other knee come and see me for a rupture ACL of the other knee.
The good knee.
Yeah. And they say immediately, I want to try this first.
Yeah.
And I can always do surgery. I know what that looks like.
Yeah.
And if they get a good heal, for the people that get the full volume heal parallel to the roof with a stable knee, it's sort of like giving them a time machine, giving them back their knee. They've got no donor site morbidity. There's no surgery involved.
Yeah.
And their rehab's a lot easier once the brace is off, because they're just getting their range of motion and strength back.
Yeah, absolutely.
And they're a fascinating group to talk to. There's about 60 of them now that have done ACL reconstructive surgery one knee, cross bracing or non-surgical treatment, contralateral knee or other knee, and we're following them up over time, over many years, and probably we'll be following them up in 15 or 20 years. I've told them, and we're looking at survivorship. Like hopefully none of them rupture their graft or their healed ACL, but some will. Especially if they're going back to high demand sport. We're looking at the incidence of osteoarthritis. So, and we don't know this yet, but maybe if you do get a good heal and no further instability, you may have less arthritis than if you chose reconstructive surgery. So that's a big statement, but that might be an appealing statistic or expectation for patients. You say, look, I'd like to try a non-surgical treatment first, and if it doesn't work, my knee's unstable, then I'll get surgery.
Yeah, sure. Yeah.
So it's not an emergency. The surgery is only emergency if you've got one of those serious concomitant injuries. Bucket handle meniscal tear.
Meniscus,
we talked about earlier. It's an emergency if you're a professional athlete, or you're in the military, and you're relying on that knee to be stable to.
Well, that's your income.
Exactly.
Yeah.
So then it's an emergency and make a decision on, I want to get surgery ASAP, so that I'm back in 12 months' time. But for the vast majority of our patients, they can sort of cool their jets and think about, do I want to try non-surgical treatment? And I've always got surgery. They're sitting there if I need it. Like they do in Scandinavia. They for the majority of their population, excluding the elite athletes that we just talked about, they get sent to physiotherapy for a trial of rehabilitation, and then you cross over.
Sure.
If your knee doesn't feel quite right, they don't let them go back to soccer without very careful decision making, because you don't want to suffer that calamity of a high energy giving way that trashes your knee.
Yeah, definitely.
And
what about so now talking about the recovery process of going, okay, you've done the 12 weeks. What happens then if they've healed well and they've done 3 months? In their head, they're fine and they're fixed. Is that following again? We've still got to go through the rehab and get you back because you haven't used your knee for 3 months. What's the recommendation in the process if you have healed, and then if you haven't healed after the 12 weeks? What are the two sort of pathways there?
So early on in the research, 5 years ago, we hadn't worked out our MRI classification system. So we didn't have those predictors of where you will land on the spectrum of healing outcome. So, patients would come in here and we'd either be a spectacular success or a spectacular failure. And but all the patients I spend a lot of time with, and the doctors in New Zealand who are doing this treatment, and now there's doctors all around Australia who are performing as the head clinician in the treatment. You hopefully spend a lot of time with the patient, their partner, husband, wife, or their parents in that initial consultation, giving them all the necessary information on what does the 12-week clinical consultation look like, and that we're going to get you back for an MRI, and then we'll decide at that point in time where you've landed on the spectrum of healing. How does your knee examine? What does the MRI look like? And what a success is for you, depending on how demanding what you want to do in 12 months. I tell them right from the get-go, this is the same as surgery. I think it's a 12-month recovery to return them safely to sport, because we think it takes 12 months for the biology of healing of that ACL, which is terribly long. Like, you're better off breaking your leg, to be honest.
I tell people that all the time.
It's one of the slowest healing injuries in sports medicine. You dislocate your shoulder, you're back in 6 months. You know, so it's a terribly long process, but you need to set their expectations from the beginning, so they're not devastated and suffer anxiety and depression, etc., because you're over-promised and under-delivered.
Definitely.
So they know in their mind at that 12-week consultation that they might be crossing over to surgery if they examine poorly, or the MRI is thinned and elongated or healed the lateral wall, and biology hasn't come to the party, and that's okay. And they say, well, look, we tried. I'll never die wondering I should have done that treatment back in 2024. So, but the ones who we think are successful at 12 weeks, they examine well, the MRI looks, there's a good volume of healing, thickness, trajectory through the knee. Then we say, look, this is great, you've done well. And then I say, look, that's a healing ACL. It's young and immature. It's fragile, just like a graft would be at 12 weeks. You need to look after that. And if you go anywhere where you may get bumped, say like by a human being or animal, like a dog park, a farm, a party, a concert, an airport, have a brace on to protect your knee. You could use the brace you've been using through the bracing protocol. Put it on as a declaration to the universe, I'm injured, and protect your knee. If you go anywhere it's unstable ground, wet, slippery, have your brace on. Because we have had people re-rupture their healed or healing ACL at week 14, week 16.
Because it's not healed after 12. That's the start of its
healing.
So,
and it's got disorganized type 3 immature collagen. We believe in the rupture zone. So you got rupture zone that becomes healing zone. Then healing zone remodels over many months. And that's a very intriguing part of this piece of this research is, and as we talked about critics earlier or skeptics, they say it's scar tissue. And look, everything is scar tissue in the body that's injured and then heals, except bone and liver. So those two tissues, bone and liver, usually do remodel back to normal, whereas skin, tendon, ligament heals with a variable scar. Now, at the moment, my hypothesis and the research group, interrogating or investigating this phenomenon of ACL healing, believe that there's a continuum, so that some people get excellent healing with beautiful integration in their healing zone, and on MRI at 12 months, it's black, it's thick, and an MSK radiologist would say, why are you showing me that MRI? It looks perfect. There's nothing wrong with that ACL. So that's the gold, Shangri-La or pinnacle of healing. And then from there, there's that might be a little bit patchy or heterogeneous, because essentially that's probably not so well organized collagen. And now what does that mean? And is it more likely to rupture? Probably yes. But you'd have to put a significant force through it to re-break it, from what we're finding from our research. That they're surviving. And with the greatest respect to surgeons, and I love surgeons, my father was one, I've got a lot of friends and colleagues who are surgeons. The graft that gets put in has a spectrum of integration or healing. Some of them get beautifully integrated and the collagen's really strong, and others have areas of deficiency. You might get an area that's mucoid, not so well organized collagen, which is a weak link in the chain. And it's not the surgeon's fault, it's not the patient's fault or the physical therapist, it's just biology. So that's why it might be a good idea to get an MRI of your ACL reconstruction at 12 months, just to see how's the graft looking. Is it healthy? Is it well integrated? And some elite surgeons are doing that now. So Yeah, so the conversation is 12-month recovery. At 12 weeks, hopefully we can celebrate that we've achieved what you're hoping for.
Yep.
And if someone like my age, I would be quite happy with a thinned, elongated,
Yeah.
because I don't sidestep
Yep.
anymore. I used to a lot.
There's no high
when I was
velocity
younger.
AFL in there.
So people just want to walk in a straight line, swim, do
Yep.
strength and conditioning,
Yep.
cycle. They might be quite happy with a thinned, elongated ACL that's got a
Sure.
bit of proprioceptive input, a bit of static stability, and then the younger, high demand wants a full volume heal. So, and then you say it's healing, and we've got another 9 months of you growing your ACL, and I want you to go to the physio. I tell them to be very careful in the first 2 months, not to go too hard in the gym. So if they do very jerky, fast velocity, heavy, leg press,
Yep.
I think you can hurt the healing ACL. You can also hurt a healing graft,
Yeah.
because
sure.
it's young and undergoing transformation from a tendon into a ligament. So you can just say, look, be very scientific, listen to your physio.
Yeah.
The progressions need to be slow and steady, and it's criteria based. And then also, by the way, we need to optimize your biology to maybe, try not to smoke, don't vape,
Yeah.
drink a little bit less alcohol, get plenty of recovery, meditate. And some people say, look, I want to do light therapy and hyperbaric oxygen. I say, that's fine.
Yeah.
All these things, acupuncture, they may all help with ultimately what's going on inside their knee with ACL healing or graft integration, or everything outside the knee, the kinetic chain, the rehabilitation.
Yeah.
So, and then at the 12-month period, the physical therapist and the patient are getting to the end stage rehab. They're returning to training. They're doing return to sport testing, and then we need an MRI to see what's the ACL looking like now.
Yeah.
And we give it an ACL OAS score of 0, 1, 2, 3.
Mm-hmm.
And so 0 means normal ACL, it looks fantastic. 1, it looks great, but it's got a little bit of thickening or a little bit of signal that might mean there's a bit of scar in there. A 2 is thinned or elongated or non-anatomic, healing.
Yep.
It's healing to the lateral wall, healing to the femoral origin or attachment. And then a 3 is ACL deficiency,
Yep.
which is you actually don't have an ACL, unfortunately.
Yeah.
And then you need to rely on your functional stability, and and then as long as you're talking to the patient all the way through, they're fine.
Yeah.
You're educating them, setting their expectations at the right level.
Yeah, definitely.
And then hopefully once they return them to sport successfully, you say, look, by the way, don't ever stop doing these exercises while you're playing soccer, netball, AFL, touch footy. You need to, especially if they've had a non-contact ACL, that's a declaration you're at risk of ACL injury.
Yep.
Yep.
And you want to make sure they never suffer this injury again, which has got this challenging treatment, prolonged 12-month recovery. You really don't want them to get hurt again.
Yep.
So you say, please do these exercises. Get to training early and warm up your nervous system. Stay strong. Do lots of footwork training, sidestep training, jump landing training. Try to get on the front foot. Think about all the different situations that might hurt you in a soccer game, and train for them. So that's the way I talk to the patients, and I'm sure
definitely.
you guys do too. And,
It's I think from my point of view, dealing with clients with ACLs, it's absolutely 12 months for me, if not longer. I think it's difficult in the media, and obviously following sport, and these guys are coming back 6-9 months post ACLs especially. Do you find that is a dangerous return to sport time for professional athlete, or is that because they've got access to so much healthcare and so much volume of physio and gym access and etc.? Is that that reason that they've got an accelerated healing?
So we're talking about less than 1% of the community.
Sure.
But we've learned a lot from them because we're all watching, and we all and I did sports medicine because I love sport.
Yeah.
I love athletes.
Yeah.
And I love medicine, so you can combine all that into a fun career. So the elite athlete does have all those resources. They usually get sent to an expert surgeon who's what we call a high volume ACL surgeon. They're doing 150 to 300 ACLs a year.
Yeah.
They're very good at it. They've got a special interest in it. They've got a great team around them of nurses, anaesthetists, etc. So they're getting a great graft or surgeon. Then they've got a great physio. They're often very healthy. They're not smoking, vaping, drinking too much, usually, especially when they're injured. And they're just committing themselves to rehab. They've got unlimited time, more than most of us, to do their physical therapy and all the adjuncts, soft tissue therapy, et cetera, supplements, high collagen, a collagen supplement, high protein diet. They've got a dietitian with them. But biology is biology, and they're often doing serial MRI, looking at the graft, examining them. All that equals they might get back a little bit earlier than people who don't have that time and money and resources. But it's still, they're human beings, they're flesh and blood. And the graft, it's hard to say because every graft's different, but there's a time when it achieves its maximal tensile strength, and it's hard to do research on that. But different surgeons vary in their opinion. But my opinion is 12 months. So I like that number. Obviously it's different. Like some people might be reaching their tensile strength at 9 or 10 months. Others take 18 months. It's whether you want to take the gamble. And ultimately that's a big decision between the athlete, the physical therapist, the team doctor, the coach, the athlete's family, a partner, the sports science team. Everyone has an opinion of how well that patient's tracking, and when do we pull the trigger and let him or her go back to sport safely and effectively. And it's a big decision, but that's why they get it back a bit quicker.
It makes a lot of sense. I mean, that's
I think 6 months is really pushing the envelope.
100%.
Absolutely. And I guess something else you've spoken about is the collagen and when you're healing the ACL, and also protein. And in the guidelines that you sent through, there was a breakdown on weeks of nutrition and that sort of thing. So do you find that there's certain foods or supplements, that sort of thing, that benefit healing and that with the ACL?
Okay, so the biology of healing once again is so important and intriguing, and how can we influence the healing with nutrition, and how can we influence with awesome physical therapy? Hopefully the brace has done its job of approximating the tissue, or the surgeon's done their job with trying to restore anatomy with beautiful tunnel position and a really good graft. And then it's up to the biology to heal that graft or the healing ACL. And you can influence it by nutrition or supplements with what are you delivering to your body as the fundamentals or building blocks of restoring the collagen and giving the body what it needs to heal optimally. So I got a dietitian involved early on, Peter Carriage, who I've worked with for decades, and Peter wrote the nutritional guidelines based on her vast knowledge with athletes, and so that's in the educational documents for patients, and it's on that Heal ACL website. So so I'm not a dietitian, but I'd refer to a sports dietitian. Like there's Peter Carriage, there's excellent dietitians throughout Australia that have an understanding of athletes. So high protein diet and a sensible collagen supplement. Usually you don't give collagen supplements to children and teenagers, so they've got to be 18 older to supplement with collagen. You could also use vitamin C and zinc in the early stages for wound healing. I often get asked about peptides and other supplements. As a doctor, I say I can't sort of agree to that or recommend that, and I'm not going to prescribe it. But a lot of patients do it anyway. But yeah, I certainly don't subscribe to like prescribing anything like peptides or performance-enhancing drugs, etc. But some people are looking for, want to do everything, and that's okay as long as they're doing it sensibly, with some type of supervision. But I'm not going to supervise it.
No, for sure.
Yeah.
Obviously, I'm conscious of time, Dr.
Sure.
Cross. I really appreciate your time, but I just want to know what the next phase of the research for you is. What's the next sort of 10 years look like? Is it because obviously we want some long-term data and some prognosis data and things, and do we have a plan for the next worldwide cross-bracing protocol?
Okay, so another great question. So at the moment, with what we know, is it's compelling, and we're not getting serious complications. We're not hurting anyone. And there's a lot of very happy people in that 899. Obviously, 75 of the 500 who are 1 year or more have re-ruptured. Some of them have chosen to do the cross-bracing protocol again. 10 of them have. And then some have said, I just want to do rehab alone, and then some have crossed to surgery. So at the moment, there's enough clinical experience and science to say we should move forward with this and keep investigating this phenomenon of ACL healing and facilitating the healing by bending the knee. What it looks like is I'm collaborating extremely closely with the University of Melbourne, Stephanie Filbay, who's our lead investigator, and she's an excellent academic. When we get Stephanie's vast knowledge of science and getting published, and her research statistical team at the University of Melbourne, and we've submitted a second paper on our MRI classification system. That's with a journal at the moment under review. Hopefully that gets published in the months ahead. Then we've got a third paper called the predictor paper, based on the first 450 people. So the first paper was, remember, 80 patients. This will be 450. And we're looking at clinical and MRI predictors of getting a high outcome of healing on the ACL OAS score, of their patient-reported outcome measure, what the patient thinks of their knee, how they examine with laxity. But the biggest one is what the patient says, how my knee feels, have I returned to sport successfully, and what the MRI shows. So that's paper 3. Paper 4 is the people who have done cross-bracing in one knee, ACL reconstructive surgery in the other knee. Paper 5 is that we have a phenomenon called the skiers ACL, that we've seen so many skiers that we now know what a low velocity skiing ACL looks like, and a high velocity skiing ACL injury, that pattern of injury. And that's a fabulous paper. And then we've got an RCT finally. Awesome. It's a randomised controlled trial. The government, the NHMRC, has given the University of Melbourne a grant to do an RCT of cross-bracing protocol versus ACL surgery. That'll start in 2025.
Awesome.
And for all the physiotherapists listening, please be on the lookout for that RCT, and doctors. It's called the Embrace trial.
So cool. Love it. Fantastic.
And then we've got another collaboration with the University of Sydney, where a young, excellent researcher, Keely Mead, is doing a PhD on what's the ideal MRI for ACL to diagnose the pattern of injury and the other injuries that we talked about, and then also how does the ACL heal, and what's that spectrum of healing. So then we can go to the MRI people who make MRIs, the software and hardware, say look, these are the minimum requirements. Maybe we can get a 3D MRI of the ACL.
Awesome.
And then artificial intelligence, deep learning.
Sure.
And then so there's lots of research, and also I've been lucky enough to go over to Europe in the last several months, and the Europeans and the Americans are getting very interested, and so they may start their own RCT.
Sure.
For instance, on rehab alone versus one of those bracing protocols. 6 week, 8 week, 12 week. or bracing 30 to 90,
Yep.
or the hybrid
Yeah.
30 to 90, staying at 90 most of the time.
Yeah.
Then that'd be great if other researchers, in Europe, USA, Asia, Africa, start running with this and getting more data, and then we all collaborating for the benefit of the patient.
Yep.
So I think ideally in 5 years we have a lot more science,
Yep.
and the level of evidence is higher, and that's predominantly for the benefit of the patient, that they've got more knowledge
Yep.
of their options and more confidence of choosing a pathway of treatment. And hopefully it gets embedded into the treatment paradigm, not only in the countries that have the team of 4, doctor, radiologist, physio, surgeon, but those what outnumber the countries in the world that may have a team of 2. So the vast parts of the world that don't have access to surgery, MRI,
Yep.
that we can brace these young, girls and boys and get better healing outcome for them.
Yeah.
So that is what really motivates me
Unreal.
for where this may go.
Yeah. Yeah. So it's still super ever changing, and there's heaps of sort of research to come in the next 5 years. So it's super exciting, but it's good to be part of, and actually being a clinician to sort of develop along, because obviously at uni it was very much surgery. Everyone with an ACL has to have surgery. So this is really cool.
Appreciate it.
So I appreciate all your work in the field.
Well, thanks for your time, and
no worries at all.
thanks to all my co-authors.
Absolutely.
I can't do this without a lot of help.
Yep.
Thanks to the Stadium Clinic reception team who look after the patients so well.
They're amazing actually on the phone.
Yeah.
It's very, very easy to deal with them. So thank you to them.
No way I could do this without help.
Absolutely.
And, a lot of people to thank.
Yep, definitely. No, I really appreciate your time, Tom, and thank you for having us at your clinic and taking time out of your day to come talk to us.
Thank you.
You're most welcome. Thanks.
Alrighty, so that brings us to the end of our episodes on the cross-bracing protocols with Dr. Cross. A massive thank you to him for taking the time out to sit with myself and Ethan and discuss this incredible bracing technique. As always, if you have any questions, feel free to reach out to us via Facebook, which is Movement Therapy, our Instagram, Movement Therapy Oz, or on our website, which is movementtherapy.net.au. And we'll see you soon for the next episode. Thank you. Bye.